get started. Thank you so much for attending. This is Dari Safar. I'm the managing partner of Telespecialist. Tell me a little bit about Telespecialist. We're a telemedicine company founded in 2013. We provide emergent and non-emergent teleneurology services for hospitals nationally. And we want to present and talk about a very emerging topic, which is reimbursement for telemedicine. I'm very excited to have a great panel. So I'm going to go ahead and introduce the panel right here. Kyle Fajay, Kyle, if you want to go ahead and tell us a little about your practice. We'd love to hear more about what your specialty is.
Sure. Thanks. I'm Kyle Fajay. I am of counsel at Foley & Lardner. I'm a member of the core telemedicine team here at Foley. And I think I can safely say that Foley & Lardner does more telemedicine legal support work than any firm in the country. So I'm proud to be part of that group. My practice, I specifically zero in on helping younger companies get up and running, deal with issues like corporate practice of medicine, how to structure friendly PCs, that kind of thing, reimbursement, how once you get into the space, you can actually get paid, what kind of modalities are appropriate in any given setting and what each state law requires, informed consent that's specific to telemedicine. And then the other thing that I do with respect to specifically telemedicine, I do in my other life a lot of FDA regulatory work. So I advise clients in the digital health space that are in the world of developing products, figure out when and if they need FDA regulatory clearance. And for companies that are ready to commercialize in the telemedicine space, there are some regulations that are applicable to advertising and promotion that I talk through clients, talk to them about what those requirements entail. So that's sort of my telemedicine practice in broader scopes. I do a lot of health care compliance work, so fraud and abuse type issues. I do a lot of policy writing for companies. And I also do a lot of basic contracting for research and development, so clinical trials and that kind of thing. But for telemedicine, I play a little bit of the piano because if you're going to be in this space as an attorney, to be honest, you have to. So I will pause there and hand it back over.
Well, thank you so much. And my next guest is Becky Sanders, and she's the program director for Indiana Rural Health Association. Thank you. Welcome, Becky. And give us a little bit of your background.
Sure. Thank you so much for having me. I'm honored to participate today. So I've been at the Indiana Rural Health Association for about 12 years. And 10 of those years, I've been the program director for the Upper Midwest Telehealth Resource Center. We are federally funded to be a neutral party to help answer questions. We get a lot of questions about reimbursement for folks that are looking to start telemedicine programs or develop new telemedicine lines of service. So we've got a lot of resources on best practices, how to get started, those types of things.
Well, thank you very much. And my next guest is Nancy Rowe, and she's the Associate Director for Outreach for Arizona Telemedicine Program. And welcome, if you could give us a little more about your background as well.
Thank you. I am with the Arizona Telemedicine Program as well as the Southwest Telehealth Resource Center. So again, we are federally funded to be a resource for people interested in finding out more about telemedicine and telehealth. The specialty of the Southwest Telehealth Resource Center is really education and training, offering resources, and of course, the technical assistance. And we also receive a lot of questions about reimbursement. So that's something that I've started to focus on.
Becky, if you don't mind, I'd like to ask you the first question because one of the panelists brought us about, are there any differences in documentation between telehealth encounter versus in-person care? So if you could talk a little bit about that.
Yeah, sure. So the majority of the documentation from an in-person visit to a telehealth visit is going to be the same. The actual billing codes that you need to use are going to be the same CPT codes. The modifiers will be different. There's some specific modifiers that are used for telemedicine, and depending on if you're billing Medicare or Medicaid or private payer, those can differ. The best resources to learn about billing, the Medicare every year puts out a Medicare telehealth fact sheet that is available on our website. You can also Google Medicare telehealth fact sheet. For Medicaid, each state Medicaid program is a little bit different. For the 4 states that we cover in our region, Illinois, Indiana, Michigan, and Ohio, we have links to their Medicaid programs and summaries that help folks to manage that information. You can also go out to the Center for Connected Health Policy, who is the National Telehealth Reimbursement or Telehealth Resource Center, and they have a 50-state guide that they do twice a year in the fall and the spring, and that goes through each specific state and lists different information on the different laws and reimbursement from that specific state.
Well, thank you so much. The next topic I'd like to talk about is payer restrictions. And I know, Nancy, your expertise maybe might relate to this question. So one of the questions we had is there a trend in Medicare moving towards paying for primary care only in telehealth setting, or is all type of specialties are covered? Because a lot of people want to know, what are the specialties that are being covered, or just a few, if you have any information on that?
Okay, so Medicare, as Becky mentioned, there's that the Medicare telehealth fact sheet, which lists all of the telehealth services that Medicare currently covers, and they're not just primary care. There are a lot of specialties in there. With the expansion happening with Medicare, CMS itself has added some services that they're not calling telehealth. They're actually called communication technology-based services, and those are pretty much aimed at primary care. They include virtual check-ins for patients instigated by the patient and remote evaluation of pre-recorded patient information also instigated by the patient. But they also include interprofessional internet consultation, which would be a primary care provider most likely consulting with a specialist. So that would cover all types of specialties. Certainly, I think you're probably all aware of the restrictions on Medicare coverage, which are, they're called the 1834 restrictions because they're written into Section 1834M of the Social Security Act. And they restrict, all kinds of things like where the patient can be geographically, what kind of facility they can be in, what kind of provider can provide the service, etc. Congress has been chipping away at these restrictions, very recently opening up, getting rid of the geographic restriction and certain originating site restrictions for specialties like telestroke, end-stage renal disease treatment, and substance use disorder. So both primary care and specialty areas under Medicare are being expanded, but right now it's very piecemeal, and it's coming from Congress and sometimes CMS using its own rulemaking authority, but it's baby steps and piece by piece, nothing sweeping.
Well, thank you very much. Really appreciate that. And let's just move on to, I have a question regarding, for Kyle regarding telehealth parity. I think I've had a few people asking us questions about let me go to that slide. What is parity? What does it really mean? And if you can give us some, expert law advice on what does that mean in telehealth?
Yeah, sure. So, parity at its most basic level as it relates to telehealth means that states have a law on the books requiring that commercial insurers cover telehealth. There's really kind of two different kinds of parity. One is that the services for telehealth are covered, and then two, what I sort of call true parity, is when the services are covered at the same rate as an in-office visit. So that, to my way of thinking, is really true telehealth parity, when you've got services covered and covered at the same rate as an in-office visit.
In your opinion, I mean, how important do you think is parity in long-term growth of telehealth and telemedicine?
I mean, yeah, fair question. I mean, look, I think at the end of the day, reimbursement is a huge driver of the conversation. When I'm out, doing my sort of dog and pony show in the world, that's what people are interested in. If people can't get paid for their time and effort, then frankly, they're not going to engage in this possibility. I think telehealth is the future of healthcare in many, many ways. But right now, what's inhibiting the growth of the use of telehealth is, quite frankly, reimbursement. So on the one hand, you have, as has already been suggested, some limitations in the Medicare world, which again are being chipped away at. The same is true in the commercial world. And since there is definitely, a large percentage of people who are covered by commercial insurers, opening up access to reimbursement through commercial insurers, I think, is absolutely critical to the growth of telehealth.
Right. And one of the other attendees, a question regarding the states that have parity law. Is it only for certain type of care that they cover through parity, or is it for all type of services via telehealth?
Yeah, so that's, it really depends on how the legislation is drafted. I think what we typically see is that whatever is being covered under the current commercial payer plan has to be covered also via telehealth if it is within the appropriate standard of care. So, of course, it may be that an insurance company covers a pacemaker implant, for example, and that's clearly not going to be covered via telehealth, but that has nothing to do really with parity as much as it is inappropriate. You wouldn't be able to use telehealth to accomplish that implant. But where the services can be appropriately supplied via telehealth, typically speaking, what laws tend to require is that commercial insurers within the purview of their plan covers things equally. So if a plan doesn't cover some service because it's considered cosmetic, or for whatever reason, there's a set of services that are carved out of the insurance plan for in-office visits, then you can anticipate that those services will be carved out in telehealth as well, without respect to whether or not telehealth is an appropriate avenue for such services.
Regarding the cover services that are in a parity law, are you aware, or as far as the payment, is it paid as the same as services provided in person, or is it lower or higher? What has your experience been on that?
So it really depends. It depends, like I said, if the legislation calls for what I call true parity or full parity, then the legislation can specifically state that services covered via telehealth have to be covered at the same exact rate as an in-office visit. Now, when states are silent on that point and simply say in the legislation that coverage can't be denied simply because services are being provided via telehealth, but then fail to mention at what rate of reimbursement will be enjoyed, so on par with an in-office visit, then I think typically you find that telehealth will be covered at a reduced rate. And honestly, it's just because insurance companies can. If their hands aren't forced, then it's very easy to say, okay, in-office visits, we've already stated we're going to cover, let's just say it's like $80 for X service. Maybe telehealth they'll cover at $60 if there's not specific legislation directing the commercial insurers to pay at the same exact rate as an in-office visit. So in general, I think you'll see, unless their hands are forced, commercial insurers will cover at a reduced rate for telehealth, unfortunately.
Right. Well, thank you very much. That's a great, a lot of great information. So I wanted to jump to another topic, and I want to ask Becky Sanders to talk a little bit about standardization in telehealth. And do you find that there's lack of standardization in telehealth?
Well, that's an interesting question. So I'm going to ask you a question. So
Sure.
standardization in telehealth, are we talking about technology? Or are we talking about reimbursement?
Well, I wanted to talk about, both. I mean, in terms of technology and also in terms of how it's practiced. In our practice and what we do, we essentially have written a lot of the standard of care that's out there for stroke and for teleneurology rounding, and so also we have specific technology requirement for our hospitals because we just want to you'll be able to access the patient and have, for example, a certain type of camera and computer and things like that. But at the same time, the standard of care should be, in our opinion, should be the same whether it's in person or virtually.
Oh, absolutely.
Right.
Yeah, I agree. Standardization of care, whatever that you do clinically for the patient when the patient's there in the room with the provider, should be the same over telemedicine. Now, if you've seen one telemedicine program, you've seen one telemedicine program. There are so many vendors out there when it comes to technology and electronic medical records and EMRs and EHRs, that there are some underlying standards like HIPAA, but you also see a lot of variance.
Right.
In
Right.
larger systems, I do see that they standardize exactly every clinic for this particular health system gets this camera and this otoscope and this stethoscope, and that's really from an IT perspective to be able to better manage the endpoints.
And where do you see a role for lean methodology in telehealth?
I love that question. I have a black belt in lean healthcare, and really turning a visit from a provider and a patient into an electronic visit is really a process improvement. We're using technology to remove that distance barrier between the patient and the provider. So anything that you can do, and I recommend that folks that I talk to don't go and totally rewrite your procedures. Look at your procedures and see where you're going to insert the technology of telehealth. And go through the 5 whys, if you're familiar with that from a lean or a Six Sigma perspective. All of those things are about process improvement, and that is really what you're doing when you institute a telehealth service.
Right, right. And the other question I had, I know you have background on this, on if you could elaborate on discussing what's the origination site. I had a question from one of our attendees for telehealth billing. And, if the other panelists want to also elaborate on that, that would be really great.
Yeah, so an originating site is the patient site. So depending on whose reimbursement policies you're reading, they might use the term patient site or originating site, eligible originating site, rural site. I've seen a lot of different things, but basically you're talking about where the patient resides.
Right. And as far as billing, obviously there's the specific modifiers that specify right where the patient is originated. Can you elaborate on that, and how does it affect payment?
Sure. So especially for Medicare, what they're asking now on the originating side, on the patient side, is that that is billed with the normal CPT code, but using the place of service field, putting in a 02 to indicate that the service was provided via telehealth. And there, that originating side or the patient side is going to use the CPT code Q3014, and that is for a facility fee. It's around $26, and that really just covers the cost of rooming the patient.
Right, right. And is that billable by the facility, or is it billed by the provider?
Typically, it is billed by the facility, and then the provider would bill their own provider CPT or HCPCS code,
Right,
along
right,
with that place of service 02 modifier.
right. And let's move on and talk about the next part I want to discuss, and maybe other panelists could discuss a little bit about the Connect Health, and if you can discuss some of the some of the legislation that's in Congress that's affecting telehealth, and I'd like to hear your opinion and the provisions and things like that, if you're aware of it.
This is Nancy. Are you directing the question to me?
Yes, please.
Okay, so there are multiple bills being introduced in Congress this session regarding telehealth. If you go to congress.gov and search on telehealth, you'll get 53 different current pieces of legislation, and you'll get 45 if you search on telemedicine. And of course, those are just a few of the possible search terms. But the Connect Act for 2019 is really the biggest piece of legislation that everyone seems to be talking about. And that's because instead of just chipping away at small pieces of the restrictions on Medicare coverage, it's more of a broad bill. It has multiple provisions, and it's interesting. This is the third iteration of the Connect Act of 2019, and certain provisions of past Connect bills that have been introduced but not passed have made it into other legislation that was passed, like the Balanced Budget Act of 2018 and the Support for Patients and Communities Act, and those have chipped away at some of those restrictions that I mentioned earlier on things like telestroke, end-stage renal disease, and substance use disorder being allowed to be provided in areas that aren't considered rural, and substance use disorder to the home, etc. Well, this new Connect bill includes all kinds of provisions. The most important one is really the secretarial waiver provision, which would give the Health and Human Services Secretary the authority to waive certain 1834 restrictions under certain circumstances, and pretty broad circumstances, like it would improve the quality of care without increasing spending, or it would save money without reducing the quality of care, or if the patient is in a HIPSA but not necessarily rural. So giving the secretary that broad authority to waive those restrictions, that's huge. Another pretty important provision of this act is that it would get rid of the rurality requirement and would allow the patient home for all behavioral health services, not just substance use and opioid use disorder treatment. So that's a very, very big deal. It's not, a lot of the provisions of it are also aimed at just allowing the federal government to gather more data on telemedicine, which could then be used by the Congressional Budget Office to hopefully give telemedicine a more favorable score, which would lead to further taking down of those restrictions on telehealth coverage. And then you can see on that slide, yet there are other provisions that would, waive those 1834 restrictions in a national emergency, waive some of the requirements for IHS facilities, several provisions. I think there are 14 or 15 provisions in that act. But again, it's a big deal. It's very broad. It was introduced October 30th, 2019. It was referred to the Committee on Energy and Commerce and the Committee on Ways and Means. There hasn't been any further action of it, I think, for obvious reasons. This is a bipartisan bill, and it has broad support in the Senate and the House. It's endorsed by over 120 organizations, including the AMA, the American Hospital Association, the American Telemedicine Association, the AARP. But with everything that's going on in Congress right now, politically, I'm not getting the sense that it's seen as terribly likely that this bill will pass. Perhaps some of the less ambitious bills would pass. Perhaps, again, pieces of this bill might make it into other legislation, but it's kind of up in the air whether this bill is actually going to make it through Congress this year.
Right. And in your experience, I mean, some of the other bills that you think are likely might pass, is any other ones, for example, anything that would mandate the private payers to cover, telestroke and some of these things? Are you aware of any bills like that are going to that's in front of Congress?
I am not aware of any bills in front of Congress that would regulate private payers. Those are usually done state by state. So Congress is really concentrating hard on the Medicare restrictions on telehealth. And usually when CMS starts covering services, other payers like Medicaid and even the private payers are more likely to follow. Perhaps some of the other panelists can comment on this, but as far as I know, regulation of private payer mandates to cover services, those happen in the states.
So any of the panelists, if they wanted to elaborate on that, I would love to hear more information if they know about the private payers and what are the mandates in any states besides, maybe, like what we talked about in parity law.
Sure. So this is Kyle. I think at this point, the majority of states, to be honest, have something on the books, and I 100% agree that this is something that is dealt with at a state level. And again, the majority of states have some legislation addressing telehealth parity. There are a handful or so of states that have yet to enact anything addressing parity. That includes Idaho, Wyoming, Wisconsin, Alabama, Pennsylvania, Maryland, and North and South Carolina, at least currently. I think we can anticipate that those states will address telehealth parity. I think what really is, again, the critical piece here is getting states to move toward full telehealth parity, where telehealth is covered at the same rate as in-office visits. And that is not uniform across the United States. One resource that I'd be remiss if I did not point out, I 100% agree with a statement that was made earlier that the Center for Connected Telehealth Policy is great for getting a sense of legislation on a state-to-state level. We also, and by we I mean Foley, and the telehealth group recently put out, and it's publicly available, a 50-state survey of telehealth commercial payer statutes. It came out maybe a month ago or so. And if you just literally Google Foley, F-L-E-Y, and 50-state survey telehealth commercial payer, you will very easily pull up this 50-state survey. And it really does a nice job of cataloging the various issues that are addressed or there's failure to address, in some cases, legislation in every state. So, first and foremost, the survey will address, does this state have a commercial payer telehealth statute? Is there actually a coverage provision? Is there a reimbursement provision? Are there originating site restrictions, or is that unrestricted? Are there cost shifting protections? Is remote patient monitoring covered? How to store and forward, for example, weigh into the equation. So it's a really nice survey. It's free. As of about a month ago or so, it is up to date. These things, as anybody that lives in this space knows, these things shift all the time. In fact, Massachusetts, for example, has renewed effort toward true parity being considered momentarily. So, as for these states that I mentioned, that don't have anything on the books, again, I have a feeling that we will see that change relatively soon. But again, I just want to mention that that's a free resource out there. And if you're curious, for a lot of people that are interested in getting involved in telemedicine in the first instance, they're really interested in knowing what's going on in my own state. And that's a nice resource to let you know what you can expect in terms of reimbursement in your home state.
The other question I know one of the panelists brought up, and my other panelist, she's having audio difficulty, and the question was regarding any specific software that you need for telemedicine or telehealth billing. And the answer is no, you don't. I'm aware of there's a lot of software that essentially it's like a EMR or a clearinghouse software that could be used to submit claims for Medicare billing and things like that. So the question there is no. And then some of the other questions that I had on regarding modifiers for CPT codes that are used in telehealth, and I'm not sure if we cover that. If Kyle or Becky wants to answer that, or Nancy.
Sure. This is Becky. I can elaborate on that. So we talked about Medicare reimbursement and the POS 02 code. Before Medicare was using that, they used the GT modifier, and that's G as in George, T as in telemedicine. The other code that sometimes we see used is a 95 modifier, and that came out a couple of years ago from the Physicians Association, and I've seen some private payers using that, and also some Medicaid programs using that.
Right. Great. And I have another question from one of the audience. The question is there any restrictions that you're aware of in preventing telehealth services for, for no fee service, simply gaining benefit in value-based care program? I guess the question is on value-based care program, if there are any restrictions for telehealth. I'm not sure. Yeah, the question, if this, audience person is listening, if they could clarify the answer, that'd be really great. But, again, one of the other question is for ACOs, and, if anybody has any information on if there's the utilization of telehealth and ACO, and if that's being reimbursed or used as a way to save cost in ACOs, if anybody has any questions or, information on that for, in that setting for primary care.
This is Becky again. I know that with ACOs, the next gen ACOs can get a telemedicine waiver to see patients at home. For the most part, to the best of my knowledge, they're not billing for that kind of stuff. It's part of the ACO model, so they're just trying to reduce their costs. For example, a hip surgery or a knee surgery, that type of thing, they get a certain bundled payment for that, and then they have to take care of the patient and try and save money by not incurring any costs higher than whatever their bundled payment reimbursement is.
Right. Okay. Thank you so much. And I'm just waiting to see if I get any other questions. Now, regarding, I think there was a question that I might have missed for Nancy regarding trends towards private payers partnering with telemedicine providers. If you can elaborate on that a little bit, if you have some more information on that.
Sure. This is something that has just popped up in the past year or two, and I've heard about it from a couple of different states, and that is where some of the big private payers, some of their plans, Blue Cross Blue Shield, Aetna, Cigna, for example, are partnering with some of those big nationwide direct-to-consumer telehealth providers like Teladoc, American Well, MD Live, etc. And so just to give you an example, in my particular Blue Cross Blue Shield plan in Arizona, they are now offering telehealth through their partner American Well, which is also their telehealth administrator. And so if you want to receive primary care, urgent care, or behavioral health care through telehealth and have it be reimbursed by this payer, you have to receive those services through their partner American Well. And this came up, but a psychiatrist asked me about it because she's been seeing patients in very rural areas of Arizona for many years. Really, for these patients, their only option is telepsychiatry. They don't have the wherewithal to take a day off of work or pull their kids out of school for a day and then pay to travel to a location where they can actually see a psychiatrist in person. So after several years of seeing these patients, suddenly their claims started being denied by Blue Cross Blue Shield, and it's because this provider, although she's in the Blue Cross Blue Shield network, she's not in the Blue Cross Blue Shield telehealth network, which again is American Well. So this means that her patients have the option of either paying out of pocket to see her or switching psychiatrists and going to see a psychiatrist at American Well. So there are some other issues attached to this, not just for the patients, but if a patient is seeing a psychiatrist through American Well, they're going to be seeing that psychiatrist through their own device. So there's also the question of, do these patients in very rural areas or underserved areas necessarily have the devices and the bandwidth to enable a telehealth session? Currently, her patients were going to the rural, community mental health center where they were seeing her from that location. And so, the little small rural clinics are losing that revenue. The patients may not have the bandwidth or the devices needed. It's an issue for the psychiatrist, of course, who's losing her patients. And it's also come up in the context of a couple small urgent care centers that have contacted me telling me they wanted to start telehealth programs, and I've had to tell them, well, your private payer patients, you may not be reimbursed for those sessions because you're not part of that private payer's telehealth network. So there's been some discussion from those folks of coming up with a fee schedule that would charge the patient something similar to what the patient would pay as a copay if they were to go through their payer's telehealth partner. I hope that all made sense, but it's a trend that you need to be aware of. And if you're thinking of starting an urgent care, behavioral health, or primary care telehealth program, you really need to check with the private payers of your patients to see what their specific rules are.
Well, that's really interesting. Thank you so much. That's a great answer. I have another question regarding the billing company. So the question is, do small individual companies who are billing for a physician, do they require special license? And I don't know if Kyle, if you're aware, or anybody else on the panel, that do they have to have a special license to bill for physician services?
No, Darius, this is Meredith. Have a
okay.
license.
Hi, Meredith.
Hello.
Great to have you on your audio back. Great.
Yes. No, we don't have to have a special license. You need to have an agreement with the physician to be able to do their billing, and you have to be compliant with rules and regulations.
Okay. Now, the other question I have for Meredith regarding enrollment, for in order to bill for a physician, what do they have to do in terms of enrollment in the plan? Do they have to be enrolled in any plans, or how does it work?
So we started billing, and we did receive payment from Medicare as long as the physician was enrolled with them. We are now in the process of working with the commercial payers and getting them enrolled. So basically, off of our claims, we're kind of doing a manual process, since this is new to everybody, of finding out if the patient has out-of-network benefits, if we can get it paid that way, or if they're denying it because they're completely out of network. And I'm also working with our credentialing person, Brittany, to make sure that we are getting all the physicians on the right plans.
Right. Well, thank you so much. And as far as private payers, are you aware of what is the process of enrolling physicians of private payers? Is it per contract base, or is it like national? Do you have any information, or anyone else on the panel, if they can elaborate on that?
My understanding is that it can be both, and it depends on the insurance company.
Okay. And let me introduce, because I know Meredith had some issue with her audio, so I didn't get to introduce her. She's with Premier Billing Network, and Meredith, if you can give us a little more information on your background in billing, and and your experience with billing for telemedicine services.
So I've been doing medical billing for about 25 plus years now, and we do, Premier Billing Network does billing on the physician end. So we only do physician billing. We do no hospital billing. And the telehealth is something new, and I find very exciting because it's constantly changing, and you have to keep up with everything to make sure that you're doing things correctly.
Right. And as far as I know, there was a question, and I tried to answer that. Hopefully, the question was, do you need any specific software for billing for telemedicine, or is it the same software that you bill other medical services?
You use the same software. You're using the CPT code books that is compatible with the billing software that's out there.
Okay. I'm just trying to see if there's any questions that I'm missing here that the panelists might have. Let me go back to. So you had a question that somebody asked about the. I think maybe it was Becky mentioned Regulation 1834. If you can expand, what does that mean right now, and how does that affect telemedicine?
I think that might have actually been me. This is Nancy. So
okay.
It's not actually a regulation. They're referred to as the 1834 restrictions because they are written into Section 1834M of the Social Security Act, and those are the restrictions that I think Becky mentioned. And the biggest one is that to be reimbursed for a telehealth service under Medicare, the patient has to reside in a rural area that is also a health professional shortage area, or in a county that does not contain a metropolitan statistical area, which is a huge problem, especially out west where the counties are as big as some of the eastern states. And you can actually, there's a link to this on that the telehealth fact sheet that Becky and I have mentioned. There's a link to a payment eligibility analyzer where you can actually type in the location of your facility and see if it qualifies or not. But then there are also other restrictions, including a really short list of facility types that the patient can be in, a short list of provider types that can see the patient, some other restrictions, but those are the big ones.
Right,
so those are the things that these different laws coming out of Congress and different regulations coming out of CMS are trying to get around by, saying, for telestroke, it doesn't have to be in a rural area. For substance abuse disorder, it doesn't have to be in a rural area, and it can even be in the patient home. The patient home is not generally considered an originating site under Medicare. And then I might have mentioned, but CMS has come out with some specific services that they're not calling telehealth. They're called communication technology-based services. Because they're not called telehealth, they're also not subject to those 1834 restrictions. Same with remote patient monitoring. That is not referred to as telehealth by Medicare.
Right. The question is to explain the difference between distant site and originating site billing and reimbursement differences, or if they
Sure. So we talked earlier about the originating site being the site of the patient, and the distant site being is the site of the provider. So the originating site or the rural site or the spoke site is the patient side. The hub site or the urban site or the distant site is the provider side. So the provider bills, and I saw a question about what codes are commonly being used. Most of the E&M codes are covered, and we find a lot of transparency in what Medicare does with their Medicare telehealth fact sheet. We see the most transparency in the billing for that, and that's only a list of about 100 codes out of, 10,000 CPT codes that exist. So it's a very small portion of those codes, but they're normally E&M visits. There's codes out there for behavioral health, for end-stage renal disease, psychotherapy, these types of things. And then it's really, the originating site bills for their facility fee and the provider site bills for whatever service they've actually provided.
Well, thank you so much. And there's another question regarding what is the most common telehealth billing codes being used in the U.S. as of right now. And I know I'm aware of the CMS website that has the telehealth codes. But are you aware of any specific codes that are commonly used or in any specific areas of telehealth?
I personally am not. Maybe the others are. I haven't done any analysis of those.
I couldn't comment on which codes are used the most, but I believe behavioral health is probably the single broadest use of telemedicine, and it's certainly one of the oldest. So I would guess, just based on a statewide survey that we did here in Arizona, behavioral health and primary care were the biggest, the most often used.
Okay. Yeah, because it seems like behavioral health had had less restrictions in terms of geographical use. So that makes a lot of sense.
Well,
but
for
yeah,
specific, for
right.
specific services only, though, for opioid use disorder and substance use disorder right now, and then Congress is working on trying to expand it to behavioral health in general, with several different bills being introduced on that.
Right. And looks like, I think there's another question regarding the telehealth use in prison and jails across the United States. Are you aware of, or if anybody could comment on that, what is the usage there? And I could imagine it's probably for behavioral health more than anything else, but are you familiar with any prisons or jails that are using telehealth right now? If any of the panelists have any information on this.
I can comment on that just broadly. Yes, certainly prisons and jails are using it because it saves tremendously on transporting prisoners. The cost of transporting a prisoner is huge. So using telehealth is very common in jails and prisons.
Okay. And I think we're kind of running short out of time, and I don't see any other questions. So I just wanted to, again, thank the panelists, Nancy Rowe and Becky Sanders, Meredith Allison, and Carl Faget for reaching. And one of the audience had a question regarding reaching to you if they have any further questions or want to use your services, and I just want to make sure that if anyone has any objections or consent, or can we post your information or your link to our website?
That's fine.
Of course.
Absolutely.
Well, thank you so much, and I appreciate it. And hopefully, we can get you back on and in a future date and do this again. I really appreciate it. Thank you so much.
Thank you.
Thank you.
Thanks for having me.
Thank you.
Bye-bye.
Bye-bye.